complications can occur up to 20 years. So there are many different variations of how to follow up a patient. Some literature you read will say follow them every week for the first month, then every 3 months for the next 6 months, and then yearly for the first 5 years, and then every 5 years for the next 20. So these can occur quite late. So you definitely want to keep eyes on these patients should you encounter them. Okay, now we'll move down to mid-face fractures. The nasal fracture, this is quite common, especially in the teenage years, if children and young adults who are into sports. I will not get into the anatomy. Again, this is another topic that I think very easily we can spend an hour on, just probably the anatomy alone. But here, just a refresher of the arterial supply, so very, very vascular region. If you have a nasal bone fracture, pretty straightforward when it comes to closed reduction, and which is most of the time all you need for these patients. So you need just a few instruments, some good local anesthesia, and Afrin, generic name oxymetazoline. There are two different types of forceps or instruments you could use. One is called an Ash forceps, that's the one on the bottom left, and the other is a Boy's elevator, and that's what I tend to use for these. So essentially, you place this into the nose, and then along the nasal bones, and you'll have one hand out on the nasal bridge, and you are just reducing that fracture. If it's done, within a week to 10 days or so, you will either you probably hear the bones resetting, and that's always very satisfying because you did it. But otherwise, if it's a little bit older of a fracture, you may not. You just kind of feel it as you're manipulating the nasal bones, and then you'll see it, of course. Afterwards, these fractures do need to be splinted, and so there's a couple of ways to do that. One is with nasal packing. That's at the top right there, and essentially what you're doing is you are just layering strips of gauze, iodofoam gauze or whatever gauze you use, and that will stabilize internally, the nasal bones internally, as well as provide some support to the septum. And then there's something called the Doyle splint that we have here in the States, and that's on the bottom right, and that you just lube it up with some lubrication jelly or bacitracin, and that's placed into the nares alongside the septum, and that gets sutured in. And then, of course, you always want to have some type of external splinting that you would leave on. If this does not work, then of course you would have to do an open reduction, and that would be in the same vein as doing a septorhinoplasty, which we won't get into today because that will make this lecture extremely long. Okay, let's talk a little bit about nasal orbital ethmoid fractures, or NOE fractures. So this is a complex anatomy in the midface. Many things attach here, live here: the lacrimal apparatus, the medial-temporal ligament, and the anterior ethmoidal artery. So what are some of the signs? This would be, a patient would get this again with a direct blow to the center of the face. So you may see the classic signs for a nasal bone fracture, which means ecchymosis. You may have some periorbital edema. There may be telecanthus, and there may be a widened nasal bridge. So the average intercanthal distance for African males and females is about 34 millimeters. So if you cannot get a good reading because of the edema, one of the things you can do is measure, sorry for my typo, is measure the interpupillary distance and then divide that by 2. That's a quick way to figure out how much displacement is present. So the diagnosis of these fractures, aside from looking at signs and symptoms and perhaps a CT scan, let's say your CT scan is down and you cannot get any imaging, what you will do is you will place some gentle tension on the lateral canthus of the eye while you palpate the medial canthal tendon. And if you can feel movement at the medial portion then you know that there is an injury to the medial canthal ligament, and so there's most likely a fracture present there. So here is just another quick schematic of where the medial canthal tendon roughly inserts along this NOE area. And in this case, there is a classification called the Markowitz classification that is helpful to learn. And so it's 1, 2, and 3. 1, 2, and 3 are the classifications on the very top where it says A. That is 1. And so what you have is a fracture of this region, but the medial canthal tendon, it's attached to a large portion of that bony fracture. So pretty straightforward. And then B is just showing that bilaterally. And then when you look at C, you have now more of a comminuted appearance of the NOE fracture, but still the medial canthal tendon is attached to a segment of bone. And then the very last one, where it says E, is that you have a detachment of that medial canthal tendon, and you have quite a comminuted NOE surface there. So this is helpful because it will guide you as to what your treatment will be. So moving on to the treatment, you will need a coronal incision and plus or minus an intraoral incision, depending on how you will be plating this. For a type 1 fracture, you want to have 3-point stabilization. So the nasofrontal junction to the nasal complex, which is here. Can you guys see me as well, or only my slides?
We were seeing you before, but right now we only slides.
Oh, only my side. Okay, so you can't see where I'm pointing. Okay. All right. Well, the 3-point stabilization, your nasofrontal junction to your nasal complex, your nasal bones, obviously, your nasal complex to your maxillary buttress, and then the nasal complex to the infraorbital rim. If you have a type 2 fracture, so now you have some bony fragments that are present, you want to reduce those fractures with a wire. So this is pretty old school. I have a few attendings that still probably like to use this, and it's great. It's a good technique. You take a very, very thin wire, and you basically reduce all those small fractures. I don't think they make plates small enough for this. And then you want to have some rigid fixation of the remaining larger areas of bone that have fragmented. If you have a type 3 fracture, then you do need to reattach that medial canthal tendon by something called transnasal wiring. That's just a very fancy way of saying you take a very tiny wire, you place it through the tendon, through the bone from one side of the fracture, and it's basically like a horizontal mattress suture. And then you exit the opposite region and then bring that back again to where you entered, and then that's how you would stabilize that canthal tendon. I think I have a picture here. Okay, so just some more examples. If you guys want to take a screenshot of this website, this is the AO website. It is really great for facial trauma. If you're familiar with it, that's amazing. If you're not, definitely spend some time. The pictures, most of these photos these schematics are from the AO, but it's very helpful. And then there's also rationale behind treatment. So on the right, what we're looking at is the medial canthal tendon, the ligation of that. So you can see the wire has been passed through those tendons, and then again up through the nasal portion. And then once that is tightened, the wire is stabilized to the nasofrontal region with a screw. So, okay, orbital wall fractures. Again, I had to shorten this because there's lots of different orbital wall fracture patterns. But the most important one you need to look out for is the blowout fracture with the trapdoor. So a blowout fracture refers to a fracture of the orbital floor where the contents have been displaced into the sinus, but the rim, so that the most superior portion of your orbital cavity, may be intact. This is often seen in children. So why does that happen? And why does this happen in kids? Well, their bone is quite spongy, and so their bone can take the impact of the force. The orbital floor then fractures, and the contents fall out. The contents in particular that we're worried about is the inferior rectus, and then the orbital floor snaps back into position, and so that's called a trapdoor fracture. This is a surgical emergency. I will get into that in the next slide, but just in general, when we're talking about orbital floor fractures, excuse me, there are some common signs and symptoms we will see. You will see the patient will have somewhat of a paresthesia. They will have a limited gaze, and that should say forced duction, not forced suction. But a forced duction test is done where, with a thin forceps, perhaps something like a Gerald forceps, the inferior rectus is grasped gently at the depth of the sulcus, and the surgeon will then attempt to mobilize the globe. And if it moves freely, then you do not have entrapment of the inferior rectus. However, if you have difficulty mobilizing that globe, then that's pretty much positive. That's a positive forced duction test. So first what you do is you'll just ask the patient to look up and to do the different phases when you're doing your exam. And you will notice that the one eye, the unaffected eye, will be able to move freely, but the eye with the fracture, the patient will not be able to look in an upward gaze. So, and of course, they will have the paresthesia and the ecchymosis and those signs. So a CT scan is helpful always, and as is the sagittal cuts, which you can see on the bottom right. So you can see the floor is missing, and then there's probably some blood in there and other contents of the orbital cavity that have been displaced. So we had mentioned then entrapment. This requires immediate treatment. So this is very important because otherwise the inferior rectus muscle will become necrotic and the patient will end up with a permanent diplopia. One thing to be mindful of is something called the oculocardiac reflex in orbital fractures. So this is a triad. This may be on your boards as well. So this is a triad of bradycardia, nausea, and syncope. And this is due to the ophthalmic branch of the trigeminal nerve and the vagus nerve being stimulated when the patient is moving his or her eye. This reflex is positive if the heart rate decreases by 20% within the first 5 seconds of an extreme gaze. And it usually becomes positive when the patient is looking away from the direction of entrapment, so a superior gaze. So you want to be mindful of this. So what is the treatment of an orbital floor fracture? So I do a transconjunctival approach, which is what we're looking at here. When you do a transconjunctival approach, so this is lovely because the incision is hidden. It is deep to the lower lid, and the caveat to this is that you do have to do a lateral canthotomy and inferior cantholysis. So if you look at A, that's the lateral canthotomy, and then B, that's the inferior cantholysis. So the surgeon is separating that canthal ligament from the lateral aspect. And so when you do that, you have great exposure. So I use something like the picture shows on the left side. It's a mesh with a titanium. Well, it's a titanium mesh with a Medpor type covering over it, and you can use that, or you could use. Some people like to use a burial graft, which is nice because it's autologous, but it does require a second surgical site. So what are the complications for orbital fractures, in particular orbital floor fractures, diplopia? One thing to be very mindful of is does the patient have the double vision, the diplopia? Is it present when both eyes are open or just one eye? So binocular diplopia is what we expect in the trauma. However, if the patient has monocular diplopia, this indicates that there's a problem with the globe. So it could be the lens, it could be the retina or the pupil. So this is a ophthalmologic emergency. So this, you definitely want to call your colleagues and have them assess the health of the globe. Blindness often occurs due to bleeding, retrobulbar bleeding. The signs that you will see, the signs that you will see is that it will be painful. The globe may be proptotic. The patient will not have visual acuity compared to baseline. There may be difficulty moving in all gazes, and there will be increased intraocular pressure and papilledema if you do an exam with your ophthalmoscope. So you must treat this within 2 hours. This is a medical emergency. There is medical treatment for increased ocular pressure, which I have listed there, consisting of mannitol, pseudozolamide, and some steroids. But it is surgical treatment is the answer for retrobulbar hemorrhage or retrobulbar bleeding. Other complications that can occur in ophthalmos, which just means that the globe has now become inset into the orbital cavity. So more than 3 millimeters is cosmetically unacceptable, but also will lead to visual defects. So you can see this often when the zygomatic fractures are present. I have a picture of this coming up where you will see that the zygomatic body moves laterally and posteriorly. And so for an ophthalmos to happen, you have to have either an increase in the size of the orbital cavity or a decrease in the orbital contents. Or there's a disruption in the globe, in the ligamentous structure of the globe. So things that can cause this would be fat atrophy. So that would be a decrease in the orbital contents, as well as contracted retrobulbar tissue, and a dislocated trochlea will cause a change to the ligamentous structure of the globe. Other things would be lacrimal duct injury. Okay, so here's that picture I was describing. When you have a fracture of the zygomatico-maxillary complex, you can see where the orbital cavity can be affected. So this, even though this is primarily diagnosed as what we call a ZMC fracture, be aware that there could be a change in the patient volume if the orbital portions of this fracture are not properly reduced and fixated. So this is a pretty straightforward fracture. You would address this similar to you would address a Lefort and an orbital floor fracture. So the body of the zygoma that's been displaced needs to be replaced, needs to be reduced, put into position, and then needs to be stabilized. So typically that ZF suture, so where it says on the right, it says number 1, we typically put a plate there. We put a plate at number 2, which would be the inferior orbital rim. Of course, if the orbital floor is affected, then that needs to be plated. And then there is a third plate that is present that we will place on the maxillary buttress. So 3-point fixation is the minimum. Some textbooks will tell you need 4-point fixation, and that could also be at the arch, the zygomatic arch. So this is just a close-up of what I had just described. So you can see the 3-point fixation is present at the maxillary buttress and at the inferior orbital rim, and then at the ZF suture. Okay, so let's talk a little bit about Lefort classifications. Renie Lefort was a French surgeon, and there's different stories as to how he came about this fracture pattern. One was he took cadaver skulls and dropped them from a building and looked at the fracture pattern. The other story is that he assaulted these cadaveric heads with some type of I don't know, maybe like a bat or pipe or something like this, and then he studied those fracture patterns. Both are kind of weird, but now we have a great classification for fractures of the maxilla. So Lefort 1, the force is presented at the level of the roots of the teeth, of the maxillary teeth, and so that's your straightforward fracture right across under the piriform aperture. All of these fractures extend to the pterygoid plates, so that's something to keep in mind. That might be a test question. For it to be a Lefort fracture, not only does it have to have this pattern from the frontal view, but from the sagittal view, there will be fractures of the pterygoid plates. A Lefort 2 fracture is a fracture through the nasofrontal junction, and a Lefort 3 fracture, which is what we call a craniofacial disjunction, is through the ZF sutures as well as through the nasofrontal junction, and again, through the pterygoid plates. Let's talk a little bit about occlusion. When we are reducing fractures involving dentition, occlusion is important. And so this is just a very quick way to ensure that your occlusion is appropriate if the patient has a class 1 occlusion. So this is what we call a class 1 occlusion. What does that mean? It means if you look at the lines, the molar tooth that we see here, that cusp, so the first cusp, the most medial cusp, which we call the mesobuccal cusp, that cusp sits in that groove of the mandibular molar, the mandibular first molar. The canine, the cusp of the canine, sits between the mandibular canine and the mandibular premolar. This is a class 1 occlusion. Most people have this, but if the patient does not, you have to reestablish the patient's occlusion to the occlusion that they have. So there is a class 2 occlusion. So if we look on the left, you can see that the molar, the cusp of that molar is anterior to the groove. And then you can see that the canine, the cusp of that canine is anterior to the mandibular premolar and the mandibular canine. So that's a class 2. The picture on the right is what we call a class 3, which is just the opposite. So that maxillary molar cusp is now distal or posterior to the mandibular molar groove, and same for that canine. So if this is what the patient presents with, then this is the occlusion you will have to put them back into when you are fixating these fractures. So just be mindful of that. So how do we do a Lefort fracture? I'm very old school and I do classic Eric arch bars. Nowadays they have lots of fancy apparatuses where you can use IMF screws, which are intermaxillary fixation screws. These are just screws that are screwed into the maxilla and the mandible, and then you can have intermaxillary fixation that way. They have these hybrid arch bars. These are all lovely. They're fancy, but Eric arch bars are just a standard workhorse for me. They're low cost. They're fast if you do them well, and they're very, very stable. So once your Eric arch bars are placed, you want to completely reduce the fracture, the Lefort fracture, because sometimes it may not be, it's mobile, but it's not as free as it needs to be in order to put the maxilla back into its proper position. So once the fracture, the fracture has been completely mobilized, you place the patient into IMF or intermaxillary fixation based on their occlusion. And once that is set up, then your landmarks are in the appropriate position, and then you can proceed to place these fractures. So the left side shows how Eric arch bars are placed on the maxilla. And the middle picture is showing, these are called row disimpaction forceps. And so that is just ensuring that the fracture is mobile to the point where it could be placed, the maxilla could be put back into its proper position. So you'll notice that the pterygoid plates are present there, but I don't see the fracture line going through on that picture on the right of that center schematic. And then on the far right, now you have the fracture has been plated after the patient was put into intermaxillary fixation. So the intermaxillary fixation is very helpful because it tells you, okay, everything is back into the proper position. How do I know that? Because the teeth are in their proper position. So that's how you would approach the Lefort 1 fracture. Lefort 2 fracture is extremely similar. So you place the Eric arch bars. You want to completely reduce the fracture. you place the patient into intermaxillary fixation or maxillomandibular fixation. You may see both of those phrases, MMF or IMF. And then you're going to place plate at 4 points. So the nasofrontal junction has that Y plate, and then you have bilaterally at the inferior orbital rim, and then you have the zygomaxillary buttress, so that will keep it stabilized. A Lefort 3 fracture, again, extremely similar. In this case, you may need an additional approach of a coronal incision. These patients also go into intermaxillary fixation. You may need some help reducing the zygomatic body. So what we have here is it's a bone hook. And so that bone hook goes just deep to the body of the zygoma to then bring it anteriorly. What tends to happen in these fractures, facial fractures, is the fracture occurs and then the fractured segments move posteriorly and laterally. So we do need to control for the width of the patient's face when we are reducing these fractures. So then you plate at the most stable buttresses first, and then proceed to the least stable. So you know your position of your reduced bones will not move. Okay, moving on to mandible fractures. Again, this is another topic that I could spend probably easily an hour discussing with you. So the body is the most likely region of the mandible to be fractured, and the coronoid process is the least likely to be fractured. You have two different approaches to these types of fractures. Either it's a closed reduction or an open reduction. There are also classifications of these fractures. A closed fracture means that it is just like in orthopedic surgery. It is not communicating with the external environment. An open fracture can be an obvious laceration, or it can be less obvious and more subtle. So if you have a fracture, let's say right through, the mandibular dentition through the periodontal ligament, that technically is considered an open fracture. So the signs and symptoms, the most common sign and symptom of a mandible fracture is the malocclusion. Oftentimes, patients will have paresthesia of the lower lip due to the involvement of the inferior alveolar nerve. You may see lacerations and hematomas and ecchymosis, in particular in the floor of the mouth. And then there may be some loose teeth. So, things to remember about mandible fractures, and when you are plating, or should you be plating them, is this slide right here. So there are many forces that act on the mandible. In particular, you have the forces from muscle pull. And then you have forces from occlusion. So on the very left side, the loading force that you see that's placed at the incisors, when that occurs, there will be tension along the superior border of the mandible, and then there's compression at the inferior border of the mandible. The center photo or center schematic just shows the different pulls of the muscles of mastication. So the lateral pterygoid is going to move that condyle. If there's a fracture at that condylar neck, we'll move it medially. The temporalis will move the fragmented portions of the mandible superiorly. Same thing with the masseter muscle, it will be superior, and the digastrix will be inferior. So lots of different pressures and forces are on the mandible, which can make this fracture a little bit tricky to care for. Because if you're not aware of this, you can very easily apply the wrong treatment or not enough treatment. So we'll talk a little bit more about that. Okay, so what are the indications for closed reduction? So this means we do not need to plate anything. We can place the patient into IMF, intramaxillary fixation, and let them heal for 4 to 6 weeks. If it's a non-displaced fracture, so very straightforward, and is not open, or even if it's open through the PDL to the environment, but if it's a non-displaced fracture and the patient can go into their proper occlusion, This is an option to apply close reduction. So wiring the jaws shut, as we like to call it colloquially. If the fracture is grossly comminuted, you may want to consider doing a close reduction, intramaxillary fixation. And that's because we are trying to avoid stripping the periosteum off of these fragmented portions of mandible, because when you do that, there's potential to lose blood supply, and those tiny fragments that have been comminuted can become necrotic. Fractures in growing children. So children are very robust in their healing, and so if there is a non-displaced or if there's a minimally displaced fracture in a child, especially if it's involved in the dentition, we may want to just monitor this with a very short period of intramaxillary fixation or maybe just even liquid diet. And they typically heal extremely well. And then fractures of the coronoid process and potentially some fractures of the condylar region can be treated with a closed reduction. Open reduction with internal fixation, with plating, these would be for fractures that are displaced and are unfavorable. Unfavorable just means that those muscle pull, those forces of muscle pull that I showed you earlier continue to cause the fracture to displace. If a patient has multiple facial fractures or a mid-face fracture with bilateral condylar fractures, we would need to open these patients and plate them. And that's because we need to reestablish the height and width of the facial skeleton. So that's important to do. And then a severely displaced edentulous fracture may require an open reduction and internal fixation. Okay, so we spoke a little bit about condylar fractures. I alluded to condylar fractures. There are some absolute indications when you must open a condylar fracture and treat it. And they are as follows. If that condylar segment has been displaced into the middle cranial fossa, so this is a significant amount of force, then you need to open it. Again, you would do this in conjunction with a neurosurgeon, because no one, at least no one I know who practices facial trauma wants to explore the middle cranial fossa. If you cannot achieve an occlusion with a closed technique, then you will need to open this fracture. If you have dislocation of that condylar segment laterally, and now the segment is extra capsular, so it has gripped through all the ligaments and the tendons of that condylar head, then you would need to open this. If there is a foreign body in the capsule, then you would need to open this, or if there's an open injury to the joint. So it's treated just like an orthopedic joint would be, a fracture in a joint would be treated. And then there are some relative indications. So again, it's bilateral condylar fractures that likely one side of the fracture needs to be opened. And again, this is because we need to reestablish that height. The height of the lower third of the face before we start plating or before we start reducing the other facial fractures properly. Okay, so here is a pan-facial trauma case. I'm going to escape here and let me see if I can see you all, because I don't know if we'll be able to do this. Can you still see my screen?
Yes, you can see the screen.
Okay. Well, I was hoping to be able to see you so we could talk about it, but I don't think I know how to do that. Okay, so we'll just go ahead and play. All right, so here's a patient that you have been called to examine. And I did not get into soft tissue injuries because, like I said, that could be another hour at least when we talk about all the different specialized structures in the face that need to be treated with a soft tissue approach. But for now, so we're looking at the patient on the left, and so it's a pretty significant injury. How about we go to the reconstructed 3D scan? Does someone want to tell me what type of fractures you see? And I will say I'll give you a hint and tell you that there are fractures of the pterygoid plates bilaterally. And anyone can shout out. You can shout out as all of them or just one of them and let your colleagues shout out others.
Maybe let me just try. So
Let's start at the top.
Yeah, the frontal bone.
Yeah, definitely frontal sinus. Do you think the anterior table or the posterior table or both?
I think I'm just thinking both because
Yes.
it's a 2D image.
Yes. Great.
We have the nasal bone, like.
Yep.
We have also the flow of like the orbital thing, like the flow of the orbit. That's the zygomatic.
Yep.
One, and almost everything is not.
Everything is fractured. Yeah. But we have to diagnose it because then we'll know how to treat it. So keep going. You're doing great.
The maxilla and the mandible is also fractured.
Yes. Excellent. So I agree with you. There's definitely a frontal sinus. There's a frontal bone fracture. There's a comminuted frontal bone fracture, number one, and frontal sinus, anterior posterior table. I would say this patient on the right has a Lefort 3 because you can see that there's a fracture through the zygomatic frontal suture right by the orbit, the lateral orbit. So that's fractured, and the nasofrontal junction is fractured. And I gave you a hint, and I said that the pterygoid plates were fractured. So that gives us Lefort 3 on the right. On the left side, I don't see a fracture through the frontal zygomatic suture. So that lateral orbital area looks intact to me. So I would not say that it's a bilateral Lefort 3. I would say it's just a unilateral Lefort 3. I would definitely say that this patient has a bilateral NOE, nasal-orbital ethmoid fracture, for sure, because you can see how comminuted that the medial canthus region is. If we wanted to get very specific, we could say that it is a type 1 on the right, because you can see a very large portion of that medial segment where the medial canthal tendon would be attached. That looks in place to me. Now, I can't tell because I haven't done the clinical exam to see if the medial canthal tendon is still attached or not. But if we're just looking only at this CT scan, I would say that's a Markowitz class 1 on the right. Probably a class 2 on the left because the fractures in the nasal-orbital region look a little bit more comminuted. So we've got those fractures. We have a zygomatic, what we call a zygomatico-maxillary complex, so ZMC fracture. We have those bilaterally as well. We have also a Lefort 1 fracture because you can see that the maxilla has been fractured across the piriform rim from right to left, and then there's also a fracture right through the maxilla between the two central incisors, so that's happening. And then we have a mandible fracture as well, so at the parasymphysis. So lots of fractures here. It's going to take some time to put this gentleman back together again. So how would we do this? Because everything is in puzzle pieces right now. So the first thing you want to do is expose all your fractures, because that's you need to see where everything is broken so you can put it back together again. The next thing we do is we establish an occlusion. So that's why I took a few minutes to talk to you about occlusion, because that's very important. When you have an occlusion, then you have at least your width is controlled for, because the teeth will go into position where they're meant to line up. And it's kind of like a free pass, because if your teeth are lined up in the right place, then you could say, okay, well, at least now I know the width of my maxilla is in the proper position and the width of my mandible is in the proper position. And so if you have those two bones in the proper position, then you just have to line up all the fracture segments again, like a puzzle. So then you place the patient into maxillomandibular fixation. And at that point, next you will either, there's two ways to approach this in facial trauma. It's called top up or bottom down. So what does that mean? It means either you start from the top and start reconstructing superiorly to inferiorly, or you start from the bottom. But what you don't want to do is do a little bit on the frontal, don't do a little bit on the upper third, then move down to the bottom third, and then do something in the middle. You don't want to do that. You want to go very sequentially in order. And you want to plate, you want to get the most stable segments positioned first. So as we say in surgery, you go from known to unknown. So if we were going to do this from top to bottom, let's say, if we look at the left side of this patient's face, we have a pretty good stable portion of that frontal bone. And we know that the frontozygomatic suture is in position. So that's great. That gives us some, it gives us our landmarks. And from there, we can then mirror on the other side. So always stable to unstable. And then most trauma surgeons will work outside in. So once you have established your width and your height of the patient's face, then you can work towards the middle, because that's where things are extremely comminuted and a little bit more challenging. So you don't want to start there. That would be a little bit confusing. You want to go from where you know you have proper anatomy, or it's fairly close to being reduced on its own, and then move to the more unstable portions. So that would be our treatment approach. And here's what ended up happening for this gentleman. So what you can see, the mandible has been fixated. And so we use 2 plates on the mandible. I like using 2 plates, not every surgeon does, but to control for that compression and tension that occurs from all the forces of the muscle pull as well as from functioning. I'd like to have an inferior border plate and a superior border plate, and then you've got this patient is in maxillomandibular fixation. And then you can see where all the other plates have been placed. The buttresses, the facial buttresses, so like the maxillary buttress and the frontal nasal buttress, these are all solid portions of bone, of the bony skeleton. So this patient also, it looks like they had a bone graft placed on the nose to probably recreate that nasal dorsum. So that's why you see that strange piece of bone in the center of the nose. Okay, this was a photo from fellowship. This was a case from fellowship one of my attendings did on a younger patient. So very, very tragic. If you could see that left side, there's no globe, so the globe had to be removed. And then you can see the amount of comminution from that center picture, just showing the CT scan. Does anyone want to try and describe this fracture? Or fractures?
Let me try.
Yes.
So the fractures are on the left side of the face. Mm-hmm. There is a fracture of the maxilla, but the mandible seems spared.
Yes.
The medial canthal tendon is also affected, so I think this is type 1. And there is also
effortlessly.
They might be also fracture in the lateral orbital wall, so maybe a low foot. Class 2, and also the maxillary sinus is affected, but the frontal sinus seems okay.
Yes. Yeah. So I agree. There's more mid-face trauma on this patient. So
Excuse me, doctor. Doctor,
Yeah.
there's someone who raised the hand.
oh, sure. Yes.
Ayele, can you go ahead?
Thank you for giving chance.
You're
Hello?
welcome. Yes.
Welcome. Thank you. I'm late comers and I forget the program. The case was a road traffic accident. I was a maxillofacial surgeon in Ethiopia.
Yes. Wonderful.
Yeah, I'm running maxillofacial surgery nurse in Ethiopia. And is this a case of the gunshot injury or a road traffic accident?
I think this is an MVC.
Because the management was different if it is road traffic accident and a gunshot injury. Anyways, when we come to the principle of fixation, always when there is a especially in community fracture, we can start from the anatomically reduced stable fractures.
Yes.
Always in the especially mid face, in this case, the supraorbital region that is the most anatomically possible to reduce it, or if it's a fracture. In the Marquis technique, we can come from outward to inside. That means the FZ, the lateral wall, then infraorbital, then the endo fracture will be fixed to positive. That is most anatomically most reduced stable fracture will be reduced first everywhere in the
Yes.
fracture site.
Yes. Great point. Yes.
The simple of fixation in the mid-face and any palm fascial fractures.
Yes.
There are two ways of palm fascial fracture management. One is starting bottom up and inside out, or top down, outside inside. These are two ways, but most surgeons can, even in the most reliable one is fixing or exposing all the fracture site is one of the simple. Then second is fixing of the anatomically reduced stable fracture is also the first part. So for
Yes.
this, starting from the FZ supraorbital region, then FZ, then infraorbital was somewhat with the floor, near floor of reconstruction, even the zygomatic buttress and the inferior lateral border of the frontomaxillary area bone was also communicated. So anatomically reduced stable areas always fixed for it, then the community part is latest.
Yes. Thank you. That's the best take home for you all is that
I'm also happy to get you. I'm a maxillofacial surgeon. I think this group is mostly for plastic surgery. I'm happy to see you. I think the same surgery, maxillofacial. I'm aspired to be a subspecialist in cranio or maxillofacial plastic surgeon in my subspecialist.
Oh,
I'm
wonderful.
aspired to be a craniofacial surgeon.
Wonderful. Yeah, thank you, doctor. So these cases can become very overwhelming, but just remember you're going from stable to unstable, known to unknown, and that will help guide you through these panfacial traumas. And that's it. That's all I have for you. Do you have any questions for me? I can check. Oh, sorry.
It's not a question, but thank you so much for the a nice presentation and really was interesting. But to some extent, I always considered the fourth classification as if it has to be like bilateral, like both of the right and the left side. But now we just classified it on one side, and
Yes.
it was really, it was really interesting. So
Yes.
very informative. Thank you.
Yeah. For something we always tell our residents is patients don't read the books, right? So they come with any kind of fracture, all different patterns. It's usually not extremely textbook where they have a beautiful disjunction, Lefort 3 or something. Sometimes it's a little bit of this on the right, a little bit of that on the left. So they don't read the books, they just show up.
So if you don't mind, probably we'll talk this later, but would maybe come back for the next session on the soft tissue.
Yeah, we can set that up. The lecture was getting very long, even with just the hard tissue, the fractures of the facial skeleton. I had to take quite a bit out. So yeah, I'd be happy to do one on soft tissue injuries. There are lots of specialized structures in the face. So you could talk about eyelids and the facial nerve and ducts and yeah. So we can. It's a very aesthetic region of our bodies, so we want to reestablish the function, but then also keep in mind the soft tissue aesthetics, which I think most of you know because you're plastic surgeons. So, any other questions?
Yes, I have a question.
Yes.
So I'm wondering, after you repair those facial fractures, do you also repair the soft tissue? Because I heard earlier you mentioned that when there is a fracture, you have to expose the entire region to see the extent of the fractures. So do you also do the soft tissue repair, or the plastic surgeon has to intervene at that moment?
Oh no, we repair the soft tissue as well after we have finished repairing the facial skeleton. Mm-hmm.
Okay.
Trauma call in the United States and many hospitals in the United States is divided. So it's shared by maxillofacial plastics and ENT, and so either it could be by month or it could be by week. So for example, my previous job, I was in North Carolina, and so maxillofacial surgery, we took trauma call March, June, September, and December, and then plastics took other 4 months, and then ENT took the other 4 months. So that's how we divided it. So that's pretty common in the US. I think there is a question. Aubrey?
I have a question for maxillofacial injuries. Can you intubate the patient, or is it contraindicated?
Yeah, most of these patients will be intubated in the trauma bay before they either on the field when the patient is seen by emergency medical crew, or when they enter the trauma bay, they will be intubated. When we're doing the repairs, we do have to convert. If it's a panfacial trauma, we typically have to convert that to a tracheostomy so that we can maintain the occlusion.
Yes, thank you for giving chance for me. I have no question, but relation is adding some topics on panfacial fracture is the ideal thing that must be needed in panfacial fracture, especially those that are involving the occlusion areas or tooth bearing areas of fractures. Understanding the word occlusion is very important. Otherwise, fitting only bone to bone is not very important in maxillofacial trauma patients. The ideal thing is the occlusion. The first one is occlusion, that means dysfunction. Second, aesthetic is the second one. So, functionality, that is especially for the fracture involving the tooth bearing area or occlusion is that means during fixation, pre-fixation, we must be put the patient on the intermaxillary fixation. which is very important.
It is. Your occlusion will help. Yeah, your occlusion will help guide you to place the bones where they should be. I saw a question. Let me find the question. Nope. I think the question was on facial symmetry. In complex panfacial fractures, how do you ensure proper symmetry of the face? Thank you, Shirley, for your question. So again, we go back to reestablishing the horizontal and the vertical aspects of the facial skeleton. So this is done, one, with occlusion. So if your occlusion is set properly, then you have the patient's width, at least of the lower face, and has been established. From there, as you reduce the fractures, you will see when you go from stable fractures to unstable fractures, then you can, that alone, just by reducing the fractures back into their position, that should ensure the symmetry of the face. So you have to have a stable point, and the occlusion is your stable point. That's where you start. You're welcome. Any other questions? Thank you all for my lateness. Thank you sorry about that. I am, you know what it is, Alice? I'm 1 hour behind New York. I think that's why, I think that's where I probably misunderstood. So
I'm so sorry. I should have known because it was crazy.
Yeah. But thank you all. Thank you all for letting me speak for the full hour. I know it's a Sunday evening and tomorrow is Monday. I might have to get ready. So this was lovely. Thank you for doing this. This is helpful. I think this is helpful for your colleagues, Alice.
Yeah, thank you so much. And please, if you can send us the slides, probably some of us would want to, read more about them.
I'll also send some textbooks that are helpful.
Yeah, definitely. Thank you.
Yeah, we have some really, really great ones out here that our residents use as their Bible for trauma. So very helpful. So I'll send that to you. I'll make a note to send that as well.
Over to you, Brian.
Thank you.
Yes, thank you,
Thank you very much,
Dr. Renie Daniel, for this informative session. And I also would like to thank everybody who came to attend this session for their attendance. With all the gratitude and thanks to God, I'm pleased to announce the close of this of this webinar. Yes. Thank you.
Thanks, everybody. Have a wonderful, wonderful night.